Hi, everyone. Welcome to the GBV AOR Community of Practice webinar series. My name is Sarah Martin. I'm one of the moderators of the GBV AOR COP. We'd like to thank you for joining us today for this exciting webinar on the crucial topic facing GBV specialists in the field, the issue of mandatory reporting. Next slide, please. First, I want to give you a little bit of information about the GBV AOR Community of Practice for those of you who may not be members or joining us for the first time. Our community of practice offers a virtual space for ongoing field-centered learning for those working in gender-based violence and emergencies. We currently have over 1,200 GBV specialists from all over the world in our group. It's a platform for both learners and experienced specialists to discuss challenges and troubleshoot solutions to their work. We provide a place for our members to get support from their peers, to share new resources, to brainstorm solutions to common GBV program-related problems, such as transitioning from an in-person GBV case management response to going online during the COVID pandemic, or like what we're doing today, to wrestle with the issue of mandatory reporting and how to maintain survivor-centered approach while also obeying the laws in our country. We also bring together specialists to address key topics like today. We highlight resources like the interagency GBV minimum standards to make sure that everyone in the community can benefit from learning. Next slide, please. We work very closely with our sister program of the GBV AOR, the Help Desk. The Help Desk lets members get in touch with a specialist whenever they need additional support. You can see the information here, and we'll also put it in the chat so that you have access to it later. Next slide, please. So a few things on housekeeping. This webinar will be recorded. Everyone who registered for it will get a copy of the recording as well as the different the PowerPoints and different resources that we've shared. You can always find our GBV AOR Community of Practice webinars on our GBV AOR YouTube channel. So I'll put that link in the chat for you later. I'd like to ask you to stay to the end. This is a 90-minute webinar because we wanted to give you time to discuss. We'll ask a short poll at the end, 4 questions, multiple choice, so not too much for you. We will, again, as I mentioned, share the materials from the webinar with you afterwards. And if you ever have any thoughts or comments, you can always share them with us at the gbvcop@gmail.com. We often take ideas for webinars from our members. And we ask every year what they're interested in learning about. And so if you have something that you really would like us to pull something together on, let us know. Next slide, please. So for this webinar, we're going to wait until the end to pose all of our questions to our panel. So just go ahead and put your questions in the chat for the Q&A session that will take place after all the presentations are done. All the panelists will be available then to answer your questions. What we've done in the past, if we can't get to all of the questions, we can continue the discussion on the community of practice, and we will also take any unanswered questions and try to issue a written response to them afterwards. Okay, next slide, please. So it is my pleasure to introduce you to our speakers today. We have our lead speaker is Dr. Jamie Morse, who's an assistant professor of sociology and legal studies at the University of California, Santa Cruz. But she's joining us from Europe, not California this morning. We also have Melanie Hyde, Gender Equity and Rights Technical Officer at the World Health Organization in the European region. She's joined with Saba Zarif, the GBV and Emergencies Technical Officer for the World Health Organization. Then we have our colleagues from ICRC, Maria Carolina Aiza de Figueiredo, who is the sexual violence manager. I'm sorry, I'm slaughtering your title, Maria Carolina, but also joining us today. And she'll be joined by Hannah Person, who is joining us from South Sudan, who is the sexual violence operations manager there. Now we... yeah, thank you. So I just wanted to say a word about what inspired us to pull together this webinar today. In July 2020, ICRC and the British Red Cross launched a report called Forced to Report, the Humanitarian Impact of Mandatory Reporting on Access to Healthcare for Victims and Survivors of Sexual Violence and Armed Conflict and Other Emergencies. They found that the mandatory reporting of sexual violence to law enforcement within healthcare settings can obstruct access to healthcare survivors, and it can also expose survivors and healthcare personnel to further harm during these emergencies. So while the introduction of mandatory reporting has been well intended and meant to address impunity, it has in fact created legal and ethical dilemmas. So without stealing any of their glory or their thunder, I'm going to now turn it over to Dr. Morse, who will give us a little bit of history of how this came about. Then we'll hear from the World Health Organization about what the actual guidance is right now, along with some field information from their work in the Ukraine refugee response in Eastern Europe. Then the ICRC will tell us more about, since they've launched this report, where they're at with this issue. And then finally, Hannah will let us know from South Sudan what their advocacy has been like. So let me turn it over to you, Jamie.
So thank you so much, Sarah, and thank you for inviting me to join the webinar today. So my name is Jamie Morse. I'm an assistant professor of sociology and legal studies at the University of California, Santa Cruz. Next slide. So in terms of the roadmap of the talk that I'll be giving in my time with you is to present just a piece of my research on the history of clinical standards for working with survivors of sexual violence and how those standards have been adapted for use with refugees and internally displaced persons. So kind of my starting point here is that mandatory reporting laws are often tied to evidence collection for the purposes of police investigation. So in my talk, I'm going to focus on the transnational activism for a new standard of care for survivors of sexual violence in the late 1990s and early 2000s, activism which led to the first clinical management of rape guidelines published by the WHO and UNHCR in 2004. These guidelines and subsequent ones recommended evidence collection to be done alongside medical care as part of best practice standard of care. So I will provide a brief history of how and why these clinical standards were developed, which I hope will offer a useful starting point for our conversation today about mandatory reporting. I will also discuss some of the ethical concerns that have arisen surrounding implementation of the standards, particularly when healthcare providers must navigate their ethical obligations when engaging with criminal legal systems after patients disclose sexual violence. To ground this discussion, I'm going to focus on a key challenge of implementation, the problem of dual obligations, also referred to as the problem of dual loyalty in medical ethics. So healthcare practitioners can and have found themselves with divided loyalties or dual obligation, as they tried on one hand to provide effective medical care to patients, and on the other hand to provide robust evidence to lawyers, and in contexts where mandatory reporting laws existed to comply with mandatory reporting requirements. And I'll conclude by discussing the importance of centering survivors' autonomy and well-being when providing specialized medical care. So next slide. Next slide. In my talk today, I'm going to present research from my article on the politics of rape kit protocols published in the History of Science journal OSIRIS. To chart this history, I conducted over 50 in-depth interviews with healthcare practitioners, lawyers, activists, and other experts who have been involved in this history. And this is the image for my book project that one of my wonderful undergraduates created, Valerie Garcia. Next slide. I also served as an invited expert commentator for the UK's Preventing Sexual Violence and Conflict initiative during the development of the first and second editions of the UK's Protocol and Documentation of Rape as a War Crime. Next slide. The WHO and UNHCR first created the clinical management of rape guidelines in response to feminist activism in the 1990s. Initially, these guidelines did not address intimate partner violence. Next slide. In the 1990s, global advocacy to address women's rights as human rights foregrounded violence against women as a key issue facing all women globally. And I specifically use the word women to be true to this period. It wasn't until much later that there was a more explicit focus on male victims, and much more recently on gender-inclusive care. So the UN Decade for Women between 1976 and 1985 had facilitated the formation of transnational networks of women's rights activists. Shortly after the 10-year follow-up conference in Beijing in 1995, women's rights activists advocated for the WHO to do more to address violence against women as a women's health issue. Advocacy to address gender-based violence was also part of activism to integrate sexual and reproductive health into humanitarian medicine. And the wars and genocides in the former Yugoslavia and Rwanda drew global attention to rape as a war crime and in some cases an instrument of genocide. Next slide. In response to this advocacy, WHO developed its first international medical legal guidelines on sexual violence. Next slide. So the 2003 WHO guidelines for medical legal care of victims of sexual violence, which is pictured here in the center, are used to guide a full forensic exam. To my knowledge, they have not been updated since their initial publication, but are referenced in subsequent guidance documents. It's kind of simultaneously, in collaboration with UNHCR, WHO convened an expert working group to adapt standards for use with refugees and IDPs. And you can see here the first 2002 guidelines for pilot testing that are pictured here, which were revised in 2004. At the time of their initial development in 2001 and 2002, the authors drew on US sexual assault nurse and examiner guidelines, also referred to as SANE guidelines, to articulate what the minimum standards would be. These SANE guidelines had emerged from US anti-rape and women's health movements beginning in the 1970s. And what's important about this model is that they explicitly linked the therapeutic components and the forensic evidence components as necessary to advance the rights of survivors in emergency medicine. They were also important because they were some of the first guidelines that were directing healthcare practitioners in terms of how to attend to psychological trauma that survivors experience, as well as outlining immediate medical care that could be provided if a survivor reported shortly after the assault. Next slide. So the WHO-UNHCR guidelines were seeking to establish similar rights for survivors in humanitarian contexts. And very briefly, according to these guidelines, immediate medical care resembles a routine head-to-toe physical exam, except that it combines acute medical care and forensic evidence collection. Next slide. So the therapeutic components are treatment of acute injury, emergency contraception, prophylactic treatment of sexually transmitted infections, post-exposure prophylaxis to prevent HIV, and ideally patients are linked to ongoing services and crisis support. And in my view, this specialized medical care that can be done if a survivor reports very soon after the assault is the most important part of the exam. Next slide. Excuse me. In terms of best practice, the clinical management of rape guidelines do recommend forensic evidence collection, but only if it is feasible, meaning that the evidence can be stored properly and analyzed. It cautions that evidence should not be collected if it can't be used. But assuming that it is feasible and possible according to the best practice standards, it's very similar to high resource settings where forensic evidence can include both the collection of biological specimens that may link the victim to the suspect or to the crime scene, such as sources of DNA, as well as medical documentation of bodily injury. And this documentation of bodily injury is guided by the patient's account of the assault. So the examiner is meant to record all of this information on a standardized form, and this is the example from those first clinical management of rape guidelines that are pictured here. Next slide. The standardized forms typically include pictograms of male and female anatomy, and it is this medical documentation of injury that has made evidence collection appear feasible in low resource settings. Next slide. So patient medical records can be used as evidence in court, just simply the patient medical file. However, many national jurisdictions require a medical certificate or a police form completed by a state forensic examiner. Expat doctors may or may not have legal standing to testify in domestic courts, and this is the sample medical certificate from these guidelines. Next slide. The first CMR guidelines mentioned mandatory reporting insofar as all humanitarian organizations must comply with domestic laws. But there was very limited discussion of the ethical concerns that can arise, which is the focus of our discussion today. Next slide. So these guidelines were updated in 2020, and they include very comparable elements to the ones that I've just described. But importantly, they also attend to intimate partner violence. Next slide. So today I would like to speak to one of the key ethical issues that has arisen as these standards were implemented in humanitarian contexts. Next slide. There are a number of ethical concerns, and this is obviously not an exhaustive list, just a starting point, but we can think about the challenges around the meaning and possibility of informed patient consent, how to prevent breaches of privacy and confidentiality, what to do if healthcare practitioners are working in contexts in which there are no survivor-centered healthcare services or crisis support services, where there may be no victim or witness protection programs, and this is particularly an issue if suspects are parties to the conflict, and where healthcare and state infrastructures of all kinds are weak or non-existent. So in the interest of time, I'm going to focus on just one, the problem of dual obligations, which is present in high resource settings, but is especially acute in humanitarian settings with mandatory reporting laws. Next slide. According to the World Medical Association, the problem of dual obligations, or what they term dual loyalty, occurs when healthcare providers' obligations to a patient conflict with their obligations to a third party, and in this case, law enforcement. Next slide. The helping professions seek to prioritize patient well-being and to do no harm. In some cases, a patient may not wish to report. And in contexts in which domestic penal codes criminalize any sex outside of marriage, so not just rape, but also adultery and sodomy, for example, a patient may face prosecution or imprisonment if there is insufficient evidence to prove lack of consent, which is very common. And queer and trans survivors may be outed, which can be very harmful and also dangerous. Mandatory reporting laws may also require that the patient undergo a medical forensic exam conducted by a state forensic examiner in order for the evidence to be admissible in court. In some contexts, state forensic examiners have been implicated in human rights violations, including mandatory virginity testing, torture, and cover-up of crimes committed by state and state-linked actors. So in this way, we can think of the clinical standards as kind of being overlaid on older histories of forensic medicine and older systems of legal medicine. And in fact, the abuses of state forensic examiners were one of the key reasons why the WHO actually developed the 2003 medical legal guidelines at that time. So given this legacy, practitioners have attempted to humanize forensic exams through the addition of therapeutic elements, through attention to trauma, so that they would ideally be implemented by specially trained and compassionate healthcare providers, and that is the ideal. But of course, this is not the reality in many contexts. Next slide. So to conclude, next slide. Given these challenges, it is essential to honor survivor choice and autonomy. We must prioritize survivor-centered medical care and emergency responses to sexual and gender-based violence. And I believe it is important to reinforce normative commitments that healthcare is most important. It's the most important part of these standards, and that is explicitly articulated in the guidelines. And we must really, uphold these normative commitments that healthcare is not dependent on making a police report or consenting to evidence collection. So thank you, and I look forward to our conversation.
Great, thank you so much, Jamie. Now I'd like to invite Saba Zarif and Melanie Hyde from WHO to come forward and present.
Thank you. May I just confirm that you can see me visually and hear me?
Yes, we can.
Okay, thank you. So thank you, everyone. I'm going to discuss briefly some of WHO's existing evidence and guidelines vis-a-vis mandatory reporting. We can move to the first slide. So WHO's clinical and policy guidelines for responding to intimate partner violence and sexual violence against women was published in 2013. It consolidates evidence on key elements of healthcare response to violence against women, including mandatory reporting on adult women that have experienced IPV, including other forms of sexual violence. It also offers recommendations for health workers on how to provide clinical care in line with a human rights-based approach. When considering the issue of mandatory reporting, health workers must remember that the health imperative is to provide life-saving services to survivors of GBV. In other words, it's critical to consider whether or not mandatory reporting can support the best health outcomes for the survivor, safeguard their human rights, and whether in the process of reporting it's possible to ensure privacy, confidentiality, informed consent, and choice for decision, in other words, decision-making power for the survivor. These are all key pillars of survivor-centered care that I'm sure many of you are incredibly familiar with. And to this end, what WHO does advocate for is that where mandatory reporting is instated by law, that health workers inform patients regarding the limits of confidentiality and their obligated role as health workers. Next slide, please. The WHO clinical and policy guideline recommendations have informed the development of a suite of products since it was released in 2013. We can go to the previous slide for just a moment, please. Thank you. I just wanted to share with you what some of these products are so that you have them as resources at your disposal. There is a hands-on clinical handbook for healthcare providers, a health systems manual for health managers and policymakers, a training curriculum imparting clinical care for clinical management of rape and intimate partner violence. And we also have a protocol for health workers that can be adapted for humanitarian settings. Next slide. Thank you. So mandatory reporting is a significant area of concern for provision of healthcare, and so WHO includes it as one of 6 major recommendations for how health workers should be implementing clinical care. And we'll discuss some of the evidence behind those recommendations, the WHO recommendation, in the slides that follow. So we can go to the next one, in fact. Okay. So, overall, so mandatory reporting is not recommended by WHO. However, healthcare providers should offer to report the incident to appropriate authorities, including the police, if the survivor wishes it and is aware of their rights. In coming to this recommendation, WHO evaluated 23 studies in a systematic review, looking at the effects of mandatory reporting on women that have been subject to intimate partner violence and their children. Overall, there was not very much evidence to indicate what the effects were, but health providers and women, the concerns of health providers and women did come to light through the process of this research. Health providers highlighted concerns including the time and resource requirements for mandatory reporting, the possibility that women may be discouraged from disclosing information, compromising the confidentiality and the autonomy of survivors, the risk of retaliation for health workers and for survivors, and the consequences of unsuccessful prosecutions. Women raised concerns regarding retaliation, fear that their children would be taken away, anxiety about interacting with service providers, becoming victimized by the health system, and being left with bills to pay or other undue burdens, as well as worries about their autonomy and their confidentiality throughout the process. So we can go to the next slide. And this is really where we discuss some of the rationale behind why WHO advises against mandatory reporting. So, I mean, you have here some of the rearticulations of those concerns into the way that health workers can consider how they think about whether or not the mandatory reporting is going to put survivors at additional harm. As I'd mentioned before, this is not something that WHO recommends, but WHO does recommend that trained health providers do go about a process of asking individuals about abuse if they suspect or if they identify signs and symptoms. And the process for doing so is outlined in the suite of products that I had shared with you before. We can move on to the next slide, please. So, what we talked a lot about what WHO does not recommend, but we can also take a moment to consider what WHO does recommend. So we do recommend that health workers establish a privacy and confidentiality policy that requires consent before sharing information, that they provide immediate medical care and first-line support, regardless of any obligation to report, that survivors are given a choice about reporting their experience of violence to police, and also that health workers clearly explain any obligation to report and the limits of confidentiality, including the following: what information will be provided to whom, specific information that will be reported, how the information needs to be reported, what may happen next, and the process for documentation. Next slide, please. For child maltreatment and life-threatening incidents, WHO recommends that these are reported to relevant health authorities by healthcare providers, where there is a legal requirement to do so. And some of the key considerations around decision-making, confidentiality, and do no harm are also reflected here. We can move to the next slide. Finally, humanitarian crises in particular have the potential to lead to the breakdown in functionality of not only health systems, but the formal legal and social protection systems. And this makes it all the more essential to prioritize provision of life-saving care for anyone who discloses an incident of gender-based violence. And so, again, just reinforcing that it's absolutely critical for health providers to evaluate the immediate risk of harm as a result of reporting and weigh considerations accordingly to ensure that survivors are not subject to additional threat of retaliation or risk as a result of mandated reporting. Thank you.
Okay, I will take over here. So just to add, I think what's really interesting, and to bring this a little bit back to kind of the reality that we face, and there's a tension, of course, between responding within the health system to cases of imminent harm, right? And I think often when cases do go wrong and somebody is killed, for instance, and then that person had come in contact with the health system, there can be really a spotlight and a focus on why nobody intervened. So I think responding to imminent harm is incredibly important, and that's why we have regimes around mandatory reporting. But we also need to appreciate that a rights-based approach and a survivor-centered approach is the one that will actually help to prevent and respond to violence in the long term. So we do have at WHO, we've done mandatory reporting globally and also regionally, having a look at the different reporting regimes. So globally, there is a report that actually looks at various guidelines, and globally, we're doing okay. So more than 2/3 of countries did not include a mandatory reporting requirement. So that was positive in the sense that they were respecting the rights and wishes of adult survivors. If you want to go to the next slide. But obviously, I think what we need to really have a look at is that some do still include that requirement, right? And I don't think it's necessarily such a problem when that's actually being explained to survivors in a survivor-centered way. So what we want to do is have a look, is there an enabling environment for prevention and response? Is there survivor-centered care? And what role does mandatory reporting play in that? Because most countries do have some sense or some component of mandatory reporting, whether that be for children, for example, or persons in places of institutions, institutional care, for example, who actually have a greater risk. Next slide, please. What I want to have a look, though, is specifically across the European region. So I'm going to talk about specifically our work that we've done over the last 2 years, really looking at the Ukraine war and making sure that health services are available to survivors of gender-based violence in the context of that conflict. And not just that conflict, but also the refugees who then were displaced across various countries across Europe. So what we did was in 2018 have a look at baseline data, looking at mandatory reporting across the region, and then looking at those countries, the analysis, and this was basically member states who then said to us what their reporting regimes were. And in fact, what we saw was that the majority, so about 65%, do have guidelines, protocols, and standard operating procedures that do include mandatory reporting as an element of clinical care for survivors or violence against women or gender-based violence. And only about 30% said that they didn't. So we do have a long way to go in terms of addressing that. And next slide, please. And just to let you know that the kind of approach that we take, and this is really important, I think, and sometimes we miss this, I think, in the advocacy that we can do around mandatory reporting, is that gender-based violence is a public health issue. And if we take it as a public health issue, what we're looking at is the health of men and women and gender diverse people. And we do have strategies in the European region that actually support the health needs of various groups, including survivors of violence. And we tackle that in 4 different ways. And that's looking at governance. It's also at addressing discriminatory values, practices and norms, tackling other determinants, and then looking at gender responsive health systems. So within that kind of rubric, we're really looking at, is the health system actually a safe place to disclose violence and also to seek essential life-saving care for violence? And that's not just talking about humanitarian and conflict situations. We're also talking just about health systems, and are they an enabling force for survivors to come forward and to seek treatment and what we call wraparound services or multi-sectoral services, or is it a place where they're going to be re-traumatized and their rights further violated? Next slide, please. So in terms of advocacy approaches, I think what we've done over the last 2 years is really look at kind of taking a different approach, knowing that the majority of the countries in the European region have a mandatory reporting requirement. What we've seen is that there hasn't been sufficient emphasis on a human rights-based approach. And I think we really need to emphasize here that the right to health is not just is not just a right to be healthy, right? It's the right to health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so when we take that approach and we look at the different rights that are affected when a survivor comes into the health system. So if we look at the right to health, we look at the right to confidentiality, privacy, to right to be free from non-consensual treatment, the right to safety, the right to dignity, the right to non-discrimination, then we start to have to balance those rights, obviously with the rights of a provider and their obligation to report in some cases. So I think that has been a particularly strong argument, particularly in Europe, where we have the Istanbul Convention. Now, the Istanbul Convention is one of the key conventions against combating violence against women and girls and children across the European region for participating member states. But it can also be used as a tool for advocacy for member states who are trying to undergo accession to the EU. And we found that to be quite an effective tool. I think there are various different legislative tools that can be used domestically to link that, but also to link to international human rights standards. So the other argument that I think is kind of the traditional argument that we've taken in the health sector is looking at the health systems approach. So what is the health systems approach? What is the effectiveness? What are the costs of violence? And not addressing violence. So in the European region alone, it's $366 billion in healthcare costs, yeah, for gender-based violence. So in itself, that's a pretty strong argument. And then also in terms of the way that we understand health, we talk about health needs, yeah, unmet needs. And so who is not being met? And I think when we have discussions with countries, often what they'll say to us is, oh, we have hardly any cases. We only have, 200 cases a year. And so then what we use then is the prevalence data, and we go to them, okay, so you've got this many cases coming through your health system a year, and this is the prevalence. So what's missing? Who is not being met? Where are the unmet health needs? And so there's a huge proportion, because we know that the majority of survivors do not receive the healthcare they need. Yeah, they suffer in silence. So what's really important for us to really, I think, emphasize that underreporting that we all talk about, but actually the reality is that we're missing the real picture, and we're missing them in terms of being able to provide support. And because the health system is often, and we know this from research, that after friends and family, the health system is the third most trusted place for a survivor to disclose. So we miss that as an entry point into essential critical medical care, but we also miss that as an entry point to receiving multisectoral services that help a survivor to move into a journey of healing rather than suffering in silence. So that's a very important approach that we take. What I also want to emphasize is that what we have been doing is really pushing health systems to play a positive role in prevention and response. So that means also identifying signs of violence and being able to talk about violence, to be able to raise that with patients. And what I do find is that often medical providers are not comfortable to do that. And so what we do is try to support them with the soft skills to be able to do that. And that WHO Lives approach, which is listening, inquiring, validating, enhancing safety, and supporting with services, is the evidence-based tool that we help providers, medical providers, to be able to have that conversation. Because actually, when there is an imminent risk of danger, they're critical to be able to respond to that. But if they don't respond to that in a survivor-centered way and respect that the victim often knows best when to report violence in light of the phase of violence, the imminence of harm and other factors like well-being of children held in joint custody, then we can actually do more harm. So that's really important. It's challenging because often, and I have to say this, medical professionals don't see this as their role. Often they say, no, this is the role of a social worker. This is not something I should do. I don't have enough time. So it is challenging, but we've trained over 3,000 medical professionals across Europe since 2022. The guidelines are being integrated into pre-service curricula in several countries. So we're getting there. It's not perfect. I think one of the other important things that Saba mentioned is, of course, when there is a mandatory reporting obligation, that is explained to the survivor in the beginning, because it gives them the power back. Then they can decide whether they disclose or not. And actually on the ground, often what we see happening is when that explanation is given, then the survivor will say, okay, no, that didn't happen to me, but I still want that medical care. So then that also gives us another tool to say, okay, so the person is being treated, and that's wonderful, but we're also not getting a real picture of what's really happening here. And that's because mandatory reporting is creating a barrier. So it's really important for us to focus on that. And next slide, please. So I just wanted to talk then a little bit about the Istanbul Convention, and apologies for others that are not in the European region. It's a really great tool for advocacy. Why? Because it includes a specific article around reporting from professionals, and then specifically commentary, which says that it doesn't impose an obligation for professionals to report. It just allows them to report if there is an issue of imminent danger. So I think we really need to use these legal instruments and tools where we can, and particularly the explanatory notes. And most countries will have some sort of discussion about this. And usually this can be quite helpful. And we have colleagues from Council of Europe that can help to support us here. But basically, it's also explicitly reflecting the fact that we need to respect the wishes and desires and rights of the survivor throughout the process to the extent possible. Next slide, please. And so finally, I wanted to kind of try to end on something positive. And that's why I've called it promising practice and not best practice, because I don't think we're quite there yet. But we do have some positive examples. So in Georgia in 2017, we had an amendment to the laws, which basically allowed doctors to break confidentiality to disclose, but not in cases of adult women. So basically balancing that particular issue around the rights of survivors. In Sweden, mandatory reporting is only limited to minors and persons in institutional care. And then what WHO has been doing over the past 2 years is really engaging in the context of the Ukraine crisis with Moldova, also with the Ukraine and other countries, to really take an intersectoral approach. And I think this is the key takeaway for me. And I am a lawyer by training, working with a lot of doctors and health professionals. And I think a lot of it is really a misunderstanding between sectors and what is the role of each sector. And for the health sector to really know how critical they are as an entry point for survivors. Not just in terms of that essential medical care, but that validation of the harm that's been suffered. So I think we need to go back again, always to the survivor-centered principles and really try to safeguard that space, that health space for survivors. Because without a survivor receiving that critical essential health care and being able to take that journey of healing, they really aren't going to be able to participate in any meaningful way in a justice process. And so this is why we need those two sectors to come together. And I think that's really what we've been focusing on in the European region at WHO. And we are starting to see some results. So I hope watch this space a little bit. But I really think we do need to have this intersectional approach to be able to address the issue. And thank you very much. I'm happy to answer any questions.
Okay, thank you so much, Melanie. We are starting to get questions in the chat, but we're going to come to them at the end to give you all a chance to answer them. And I'd like to now hand it over to Maria Carolina to talk about ICRC's research and your recent program that you had on this. So Maria Carolina and then Hannah.
Great, thanks so much, Sarah. So I think a lot has already been covered by Jamie and by Melanie and Saba, so I'll just dive right into it. And the purpose of my presentation is really to share with you a bit the ICRC's journey in understanding and addressing mandatory reporting more from an evidence-based research perspective, but also especially from a legal point of view. So when it comes to compatibility with international humanitarian law. Next slide. Next slide. And I think we'll skip this one since we've already gone quite into detail. So starting here, I think it's really important to reflect actually on the last point that Melanie just mentioned and go back to this question around the objectives and justifications for mandatory reporting and also how different sectors work with each other or don't on this topic. To bring us back to the original purpose, I think there is, of course, a collective interest in preventing sexual and gender-based violence and, of course, in reducing impunity. And so this is what underpins a lot of mandatory reporting requirements, or sometimes even practices when they are not legal and policy requirements. And what we've seen throughout our work is often this is prompted by several causal assumptions about mandatory reporting, and these are not necessarily evidence-based. So one, that having mandatory reporting will improve victims and survivors' access to justice. Two, as I mentioned, that it will have a sort of deterrence impact whereby SGBV will be further prevented. And in some cases where these services, both health, legal, and other services are provided to victims and survivors primarily through the public sector or through governmental services, it means it's a way of expediting that access. But what we've seen in practice and what led the ICRC and our colleagues at British Red Cross, and I see Marina Tondo here who participated in that research, Marina, feel free to jump in at any time, is that these assumptions were not underpinned by evidence, so to speak. So do we really know for a fact that mandatory reporting is effective in achieving its stated either public health aims or its sort of legal aims? Next slide. Next slide. So in order to better understand, in 2020, the ICRC and British Red Cross carried out a multi-country study, so covering 4 different regions. And these were specifically contexts that were impacted by some type of armed conflict, where mandatory reporting laws applied. And so you can find this available online. I will also post all the links in the chat, and they're hyperlinked in the presentation. But the purpose of this research was really to kind of get at some of these causal assumptions and understand the extent to which mandatory reporting might actually have unintended humanitarian consequences, and how it was influencing help-seeking behaviors among victims and survivors in these types of conflict or crisis settings. Next slide. So I think what we saw is something that today is well known, but at the time 4 years ago was often not as, let's say, explicitly recognized. So first of all, what my colleagues at ICRC and British Red Cross saw through this research was that mandatory reporting requirements in many countries were actually reducing health, and I would say even more broadly, help-seeking behavior, that victims and survivors would be kind of ping-ponged from one institution to another. So for fear of not being in compliance with these requirements, healthcare providers would send the victim and survivor to the police. The police then would say, no, you actually need a medical legal certificate. So that person would have to go to the Medical Legal Institute and then eventually end up back at the hospital with no further sort of availability or access to care. And of course, a lot of this has to do, as I just mentioned, with the fear that many healthcare providers have. I've worked in several contexts where medical professionals have explained that they've faced reprisals, violence as a result of reporting, also because oftentimes confidentiality of patient data is not secured, and that includes also the person who is reporting. And then, of course, we cannot forget, and I think we've briefly touched on this today, but it's critical, is the secondary violence and harm. So here we're not just talking about physical violence, which of course in context of conflict is a huge concern, where you might have armed actors that control a medical facility, that are embedded in the medical facility, or that otherwise, have access to this type of information. So the fear of reprisals, but as well stigma. So of course, in many of these contexts, when patient confidentiality is not ensured and reporting mechanisms are less than perfect, to say the least, it means that oftentimes, whereas a survivor might be sharing their information exclusively for the purpose of medical care, under the assumption, as Melanie said, that this information is going to be provided for a specific purpose without necessarily understanding how the reporting process will work, the assumption is that they will be protected from having their story unnecessarily shared with others. And that may not always be the case when mandatory reporting applies. Next slide. And skip, next slide. So really jumping forward from 2020 to where we are today, what the ICRC has been doing in several of the contexts where we work is trying to better understand, first of all, what constitutes mandatory reporting, what are the requirements that are in place, and then Hannah will share some examples of really concretely what can be done to address the unintended consequences of mandatory reporting. So next slide. One thing that we have tried to do, and which I would encourage everyone here to do when you are working in a context where you're not really sure what mandatory reporting means, because I think, to be clear, and Melanie and Saba, thank you so much for the diagram that you shared. I was just chatting with a colleague on the side saying it was the first time we had seen such a comprehensive overview. And what was interesting to me about that pie chart is that whereas you have 25% of countries that do have mandatory reporting requirements, so many others are not specified, or it's unclear. And this is what we've seen in our own work, that oftentimes mandatory reporting may not even be a law as such. And so that creates a lot of confusion, especially among healthcare workers and first responders, as to what they should report, when, how, to whom, and of course, then also for victims and survivors. So one of the things that we did as part of Forced to Report and the follow-up thereafter was reflect on really what humanitarian actors would need to clarify and know when working in contexts that have some type of mandatory reporting requirement. So first of all, is it a law, policy, or customary practice? What types of incidents trigger this obligation? So to be clear, and I think Jamie mentioned this, Mandatory reporting is not exclusive to sexual violence. Sometimes it's a very broad category that covers all types of non-accidental injuries. Sometimes it's specific only to rape. So to really understand what types of cases actually have to be reported. And also that sometimes it's not a report, it's just an obligation to inform or to notify, but we need to be clear on who has this obligation, also who should be receiving the report. And then what are the procedures to be followed, what exceptions exist, if any, and of course, most importantly, if access to services is somehow contingent upon reporting, which we all agree should never be the case. But to clarify these questions first and foremost, so that also as humanitarian actors, we don't risk perpetuating some of the misconceptions that may exist about mandatory reporting in a given context. Next slide. And so I wanted to share with you also a tool that could be useful in this regard. If you work in a context where either the ICRC or MSF is present, and we are working to address sexual and gender-based violence, most of the time we will have done some type of minimum analysis of the legal framework, including what types of laws apply and what they say about mandatory reporting. So if you have a doubt or a question and you can identify us in one of those contexts, please feel free to approach us and ask, and we'll be happy to share whatever understanding or knowledge we have on the legal framework. If we're not present in those contexts, what I would encourage you to do, especially if in your respective organizations or with partners with whom you work, or even governmental institutions, you can use a tool that ICRC developed, which is a checklist for domestic implementation of international humanitarian law that focuses on understanding really whether a domestic legislation complies with IHL requirements to prohibit sexual violence and also to provide quality cares for victims and survivors. There is a section specifically on mandatory reporting on page 23, where you will find kind of some key guiding questions that would need to be asked in order to understand really whether mandatory reporting requirements are compatible with some of the safeguards and provisions in international humanitarian law. And those especially refer to the duty of states to prevent and investigate and prosecute sexual violence when it occurs, but at the same time, the duty that armed actors have to ensure timely access to healthcare for the wounded and sick. And that category also includes victims and survivors of sexual violence. So something that you can look at as well as a resource. Next slide. And then last but not least, one thing that we realized over the years was extremely important, and this goes back to Melanie's point on advocacy, was really just to talk about it openly. I think many of us confront issues related to mandatory reporting, but often there isn't enough sort of sharing of promising practices or just even general knowledge or evidence on the topic. So I think many of you, I see some familiar names, may have participated in our Policy and Practitioner Conference on June 19th. And essentially the aim of this half-day conference was to really bring together experts in the fields of research, but also law, policy, and healthcare workers themselves to better understand how they approach mandatory reporting, and as we're doing here today, start moving towards a consensus. And after following this discussion that we had over half of a day, we came out with some recommendations, which are included in an article that was recently published on the ICRC Humanitarian Law and Policy blog. I'll also drop the link to that in the chat, and it's linked in the presentation. The conclusions that we came to, I think, really reinforce what many of the other panelists have said today, which is that, first of all, this question of dual obligation that Jamie mentioned is especially tricky. So it means that whenever possible, domestic legal frameworks, and that means laws around mandatory reporting, have to be compatible with IHL and international human rights law obligations. So to make sure that these are not in tension with each other, but that actually they are complementary. And that, I think, as so many have mentioned today, reporting has to be an informed, voluntary, and consensual process. And whenever possible, we advocate for anonymized reporting systems. So for example, in some countries, there are systems whereby basic data is collected on, let's say, gender, age, disability, but not data that could be personally attributed to the victim and survivor. This goes into an epidemiological database that's managed by, let's say, the Ministry of Health. And then through the analysis of those patterns and trends, there can be a better understanding of maybe prevalence and risk factors. But that never should reporting be something that is forced. And of course, something that conditions access to treatment. Further analysis and coordination, I think, is key, and that's something that's not talked about as often, although Melanie pointed out just at the end of her presentation. Oftentimes what we don't realize is that many different governmental bodies are involved in reporting, but they don't always speak to each other. And Hannah will speak more about this in South Sudan. This means that you could have the Ministry of Justice that has specific requirements, Ministry of Interior overseeing police and other law enforcement that has a different set of requirements, and then of course Ministry of Health that has its own set of priorities and objectives. And when it comes to implementing mandatory reporting, there may not be a tripartite agreement or some type of coordination mechanism where they can communicate kind of the red lines across their respective line ministries and come to a common approach. So it can pit different governmental actors against each other, and often those who suffer most as a result are victims and survivors who are seeking care. And I think something that we briefly mentioned but has to be reinforced is, of course, the local healthcare and legal systems. If reporting applies, it means that obviously the systems that have to follow up on the reporting or the provision of care have to be of a certain quality. It's unfair and it's punitive and it's harmful to require victims and survivors to report when then, as a result, they're not capable of accessing the type of care that they need, or the legal system that's meant to investigate and prosecute the case that's reported doesn't have the capacities to do so, which is something that is extremely common in conflict-related settings, but I would say even just generally globally, regardless of whether there is a conflict or crisis or not. And last but not least, and this is something that increasingly ICRC, and particularly in South Sudan, my colleagues are focusing on, is really the need for community education and stigma reduction. So we want to shift from, let's say, forced reporting to a system of safe disclosures. So what is it that could really encourage safe disclosures by victims and survivors, whether it is to friends and family or to healthcare providers? And a lot of that has to do with taking the stigma away from being able to disclose these experiences. And oftentimes what we have heard from victims and survivors is the number one reason that they won't access a health facility is not even because of a reporting requirement, but because of the treatment and the way that they will be received by healthcare workers. So doing all of these things in parallel while we try to work towards a system where perhaps reporting does not need to be forced. And in the meantime, as an interim solution, always ensuring that access to healthcare comes first. And so with that, I will hand over to Hannah, because in South Sudan, that's precisely what's been done. And she's going to talk you through a bit the process of how that was achieved and maybe some of the challenges that still lie ahead. Over to you, Hannah.
Thank you, Maria Carolina, and good afternoon, everybody. I hope you can hear me well. Yes.
Yes, we can.
So perfect. Thank you, Sarah. Yes, so my name is Hannah Persson. I'm the Sexual Violence Operation Manager for ICRC in South Sudan. South Sudan was one of the countries who was in the ICRC and British Red Cross studies forced to report back in 2020. And here, I mean, I'm sure many of you actually have worked in South Sudan already, because this is not a new problem. It's actually here. Here, I mean, there is an issue with mandatory reporting, but it's not actually linked to a legal requirement. It is an old inheritance from when it was one Sudan and the practice of using Form 8, which is basically more of a form that you have to fill out in order to take a case to court for any kind of criminal issues. Also, if you have been in a car accident, etc., you have to fill out for Form 8, and it's something that is mandatory to do without seeking healthcare, although there is no legal requirements to this. So in practice, it is something, and this is coming back to what Maria Carolina was presenting as well, that this is it is perceived as something that is mandatory, but there is no legal requirement actually when you look in for it. On top of that, I mean, when it came to Form 8, there were a lot of issues that was also highlighted with Form 8 linked to corruption with the police, that survivors also was forced to basically pay for the form in order to access health services. Again, healthcare worker was too afraid to not having this as a mandatory requirement for survivors to accessing healthcare. So there is a lot of issues when it comes to accessing healthcare imposed by having to fill out this Form 8. Yeah, and again, also, as we also have mentioned before, this is really much a multi-sectorial challenge, because there is so many different authorities involved, including the police, healthcare workers, Ministry of Interior, also the Ministry of Justice, the Ministry of Gender and Social Affairs in South Sudan, who's sitting on the sexual violence file, and the Ministry on Health. Here, so I'm going to talk a little bit about what we did following this, the publishing of this report in South Sudan. And I think also maybe here it's worth mentioning that it is a little bit of a luxury to work for an organization like ICRC in these kind of circumstances, because we also having a multi-sectorial, I mean, we're having a mandate where we actually engage with all these key ministries on different issues. So we already have good relationship with Minister of Interior, because we have a mandate where we are regularly training the police. We are engaging with the Minister of Justice, and also the Minister of Health through our health program, the Minister of Justice through the work we're doing on IHL. So we also have natural entry points to all these multitude of different actors, which I think was really helpful in this in this regard. When this study was conducted, I mean, they were looking at the existing legal framework, and thankfully also in South Sudan, there was a very clear guiding principle in the Police Act of 2022 that national police should have a human rights-based approach, which means that the right to health for victims of SGBV should be a priority over basically filling out this Form 8 or doing the mandatory reporting. And I think we did, and we had a very good police advisor in ICRC, because it's important to, obviously, instead of saying just like mandatory reporting is bad, we also have to recognize that it is an important element in the investigation process of sexual violence, but that the medical and psychological support and treatment of victims should remain the number one priority. So this was basically the the key message that we were pushing. And this is why, with this human rights-based approach at the heart, mandatory reporting should not be a precondition, or filling out a Form 8 that could prevent and delay the access for the victims of immediate health care. And this was kind of the starting point when it comes to key messages, which we started to engage with authorities. Next slide, please. So for us, some of the activities that we undertook last year was that we engaged. For us, the police was the most naturally starting point, basically. And as I said, I'm sure many of you have worked in South Sudan and know that this is a long tale, and it had been an issue. It was an issue 10 years ago, 15 years ago, and it's something that people have really tried to push for, and they basically have been very much like one step forward, two steps back. They have been things to, there have been different initiatives to solve this in the past, but nothing have really stuck. And here, so basically, for us, the entry point was the police, and we did a high-level workshop in July last year with high-level officers. And there, I think it was agreed that the best way forward was to basically to reactivate a previous standing order that the police have had from 2015, which was saying that medical care should be priority over filling out Form 8, and Form 8 can be being filled out later. So this was something that we were done with all the senior management of the police. I think it helped a bit, and we haven't looked into that, like how come, I mean, we had a very good consensus at that police workshop. We have a picture here, including with, I mean, the IGP and the deputy IGP, who were big champions for these issues, which was very helpful. But I think also because there was so much underlying corruption and mismanagement for that, the Form 8 was basically used that survivors had to pay for the Form 8, or that survivors had to also that sometimes was forced to go to the police who was not there, etc. I mean, people realize that actually it's a real issue, that this is the mandatory nature of this practice. In parallel, we also met with the key ministries to build consensus around the negative consequences of Form 8. So we had, even on the highest ministry level, a green light that this is a big issue that should no longer be. And then we followed up with the police on the finding from these high-level workshops, including to reactivate this order. And I think also, I mean, this was really much advocacy in practice, which means that we had one staff who went every day for the police headquarters to a month to require how this process went. And I think it's also worth highlighting that these are things that actually takes time. The reactivation of the police order on Form 8, it was finally done, but if the workshop took place in July, it was actually activated back in February this year. So it took over 7 months, which also gives you an idea about the process of this. Now, then when we're looking at things, I think the important here is that for us, it was important to not just, we know there was an immediate issue with the current situation. So we needed a short-term solution, which was the reactivation of the police order, but we also need to look at a more long-term sustainable solution. So now we are also looking at also what we wanted to see was the implementation of the reactivation of this police order by all the different line ministries, the police, health staff, and community. So it also comes with a lot of information sharing at different levels in South Sudan. Also consensus among all the line ministries, and also maybe a public statement about to support the new police order is something we would like to see and something we are working on. And also basically coming to a consensus among all the line ministries, what are the next steps in terms of implementation and possible further legal policy actions that is possible to basically make this an issue that can go away. Next slide, please. I was very positively surprised when the police order was actually finally published, because it was much stronger than I could ever had imagined. And here the police order is very clear. It is that the police personnel are duty bound to arrange for immediate medical care of sexual and gender-based violence survivors. It's explicitly spelling that out. It's also basically filling out Form 8 should not be a precondition for providing medical services. Then that all delays caused by police personnel is viewed as misconduct, and also that the Form 8 must be provided free of cost. If they're asked for money, it will be treated again as a serious misconduct. So the language is very strong. So right now, where we are at, and it's coming back also what Maria Carolina said, and also, I mean, spread the word is key. I mean, we have an issue in a country like South Sudan where even if this have been shared with all the police commissioners in all the states, it's not really trickling down on the ground. So we have done a lot of sharing this through all the humanitarian partners we have. We have it included as a mandatory thing in all the trainings we do for the police. So my colleague actually did a training for the police this today, and this was something that they actually told her that no, but we are usually selling the Form 8 or that they have to pay for it to cover the printing costs, etc. So there's a lot of misconceptions and these practical issues that have to be solved. And then as well as doing it at with healthcare workers, also explaining to them that this is not really mandatory and that the police can't order them to do this, as well as also explaining it to communities as well. So it's a lot of work that have to be done in implementing also the legal framework. And I think this is also important to think about in other contexts where we are working on these issues, that changing the policy or changing the law is only one step. We also need to really make sure that this policy change is also addressed in practice. And yes, so we have also done discussions with the police about support for dissemination. We are also developing joint posters and pocket guides and handbooks for the police on sexual violence, but also including this new order as well. We have developed, just to keep track on all the different activities, a roadmap for engagement, also looking at how we're engaging with all these different entities. We still are looking for more in-depth engagement with the Ministry of Health and Ministry of Justice on this topic in order to get them on board, so we can organize an interministerial roundtable event on Form 8 where we can bring everybody concerned, but also important that they have agreed before that this is the wrong practice, so we can go straight in to discuss not if this bad practice, if mandatory reporting bad or not. We'll go straight into basically, this is harmful, how do we fix this, and how do we make a long-term change. So I think that's everything, and I will hand it over to you, Sarah, because now it's Q&A.
Yes, thank you so much, Hannah. Really fascinating. I mentioned in the chat that in 2004, I worked in Sudan when it was one country and writing about this topic. And it was very vexing that they would release circulars clarifying and that it would never leak its way down to the actual doctors or policemen in the individual areas where rape survivors were. So this, work, the consistency is needed as well. So there's been lots of good chat in the chat there, and there's a couple of questions. The first one I want to ask is kind of about a multi-sectoral intervention. It's kind of picking up after what you've mentioned, Hannah, and Melanie, you as well. It comes to us from Stephen Ars. He said, in considering the long-term impact of complex traumas, how can we effectively implement a multi-sectoral intervention approach that not only addresses immediate health needs, but also ensures the fulfillment of basic rights and needs for survivors? What strategies do you suggest to integrate mental health support, legal assistance, social services, and community resources for a holistic framework? And I know we've got a lot of people with experience in the group as well, but I'll pose it first to our panelists. And if someone would like to pop in and talk about any strategies they've had, we'd be happy to hear from you. So, panel?
Sure, I can jump in first, Sarah. I think this is really important for us to also consider and appreciate that the majority of survivors, they don't receive the care that they need. They don't disclose. And in fact, survivors of child sexual abuse and violence, we look at different countries where often it's around 25 years before they disclose. So I think we need to look at this in terms of the life course and the life of a survivor. And so really, for me, the most important thing is making sure that anybody who interacts with a survivor, whether that be in a health setting or otherwise, has the skills to be able to identify violence and talk about violence in a way that respects the rights of survivors. So for me, that's critical. So let's have everybody reach that baseline of care to be able to do that. And I think then what we'll see is then be able to support those survivors through a safe process and appreciate that often it takes a lifetime. It's not like you go to a medical care once and the problem is fixed. It takes a lifetime to kind of heal and to be able to be supported through that process. So I think we need to really start thinking about it as a life course issue, but also appreciate that it's not one incident of violence. And let's talk about this in terms of gender issues in particular. We're talking about cumulative experiences of violence. And you look at that, you see that in the prevalence rates, yeah? We're talking about 1, 2, 3, incidents of violence over a lifetime. So I think that's really important to consider. Over.
Thanks, Melanie. Would anyone else like to jump in and talk about that?
I can jump in following up on what Melanie was saying, because I think also when we're talking about the continuous violence that survivors are facing, I think we should not underestimate the stigma here. And it is, in the end of the day, I think it's the only crime when you as the survivor or the victim actually get blamed for what happened. And I think we should not underrate the long-term effect of community stigma, that you actually become completely ostracized by your community. And this is, in the end, experiencing sexual violence, if that was not bad enough, the fact that if the community find out what have happened to you, you are becoming completely ostracized. And basically in many cases, I mean, if you won't get killed, you will have to leave, or you are harassed, discriminated, you are not having the same access to basic services, etc. It is that bad in many of the places where we work. And I think it have to go in much more work when we do community outreach on sexual violence. Is not just looking at, but also really enforcing the message about for the community to create a very supportive environment around the survivor, because it's, if the person have that supportive community around her, that's when he or her will actually seek help. This is not easy, and it's also something that we are also working very actively on in ICRC. We have a big program, multi-country program on that, to looking at what works when it comes to prevention of sexual violence and specifically stigma reduction.
Okay, would anyone else like to jump in? Jamie, Maria, Saba? Nope, that's okay. I just want to say one word in there too, is that we sometimes tend to operate in silos, where the mental health, working group maybe is separate from the health working group, which is separate from the GBV subcluster working group. And this is an issue that cuts across all of them. People don't always disclose where you want them to disclose. They might come out in counseling to talk about it. They might tell you in physical therapy. They might disclose to your driver. Who knows where they're going to disclose? So making sure that this is looking at mandatory reporting issues is a standing issue in your coordination groups is really important as well. So my next question, a very practical one, and you've addressed it, but I'd like to hear it again more clearly. What advice do you all give to someone who's working in a setting where there's mandatory reporting, sitting in front of the survivor? Let's just say it clearly from all of you so that everyone hears it. Who'd like to respond to that?
Sure, I can go first there. Tell them about your obligation to report, the limits of your confidentiality upfront, so that they then have the power whether or not they disclose to you. I think what's also important, and there's some really great tools actually in the WHO child maltreatment manual. I know it says child maltreatment, but actually there's a decision-making kind of framework. There's also really great kind of prompts of what to say. And I think it's really, really helpful, because it helps you have that really, really difficult conversation with a survivor, but also to make sure that they can still access the care they need, even if they say, no, of course, that didn't happen, it was a friend or whatnot. And that often happens, yeah, but they still need to receive that care. So it's a really difficult conversation, but the idea is that you respect the needs, wishes, and desires of the survivor. So you need to be upfront about that obligation. And then at the same time, of course, we do the advocacy around trying to make those laws and procedures more human rights based. Over.
Anybody else want to add in that? If not, I might ask Sarah Baird, who's in the chat, if she feels comfortable speaking, because you made an interesting comment about the informed refusal in there, Sarah, in South Asia. Do you have any, not to put you on the spot, you don't have to if you don't want to.
No, that's okay. I found it a really interesting response. It was colleagues in Bangladesh who told me about that. And unfortunately, I don't think we have anyone here tonight from Bangladesh because they don't have internet access due to the situation in the country right now. But they had come to that understanding that if they would reveal periodically just a number of survivors, that they would be, that the healthcare professionals would not need to give the identifying information or actually put the survivor, directly in touch with the police. So while, obviously the advocacy for getting rid of mandatory reporting has to continue and the education around why, I thought it was a practical way to protect survivors in the meantime, because in the best case scenario, when we think about why governments may be, feeling that this is a protective measure, it's perhaps to encourage people to do, what is seen as their job, connect people to services, let them know about what's available, and don't be too busy to do that. And so this is a way of sort of reassuring, well, we did take the time to talk about it, and you can see we have filled out the form showing that we had this discussion, but the person does not want to consent to the mandatory report.
Thank you for that, Sarah. Federica Villa, you also were raising some interesting things in the chat about how it's related often to conflict-related sexual violence to make sure that women, will get reimbursed. So linking it to peace dividends. Did you want to unmute and speak about that if you're still with us?
Hello, everybody. Yes, I'm still with you. Thank you for the mic, Sarah. Yes, I have encountered this issue in different countries, and actually, I think that this system is quite interesting, right, to reimburse potential survivors and victims of sexual and GBV, generally speaking. But then I also fear, and I have seen that survivors coming to me saying, I don't want to disclose and say that I've been violated by someone because I don't want to go under the spotlight, right? And being literally used as, oh, you are number. Have you seen how many poor women in our countries have been violated by any kind of enemies or whoever? And then it can be a very interesting tool, I would say, but then on the other side, it can be also very tricky for women or anybody survivor, because they are kind of forced to report to the police, so they are counted as numbers, and at the end they may be reimbursed at the end, but then is it worth it? That's my question, and it's very linked to me, at least. Maybe not for you. I'd like to hear from you on this mandatory reporting issue, actually. Thank you.
Anyone on the panel have some thoughts on that?
Can I add on that, Sarah? Because I think what Frederica is saying is very, very interesting. And I think also to not just, and I think also to highlight the issues which, I mean, also encountering in South Sudan, also encountered in Ethiopia, among other countries, but also when it comes to basically the legal framework for reporting when it comes to link to armed groups and the military as well, because that might not actually be the usual reporting line through the police. So even if you're reporting to police, that is actually not the reporting line that you then can actually end up in actually having in order to access justice, because that will more be going to military court, and it's not really sure that you make these referrals as well. So this is also something that is very, very confusing on how to do that system as well, specifically if you have been raped by the military groups. And I think this is issues that we actually have encountered in South Sudan, where the survivors can't really get access to healthcare services because they don't have Form 8, but they can't get the Form 8 from the police because they have actually been raped by the military. So this is not actually the police jurisdiction. And I think this is an issue in other areas as well that also maybe need to be clarified even before we even talk about the idea of repatriation. And I think, but this is also a very important, it is a very important, even if you would get some kind of reimbursement afterwards. I mean, it's also loads of issues coming with the stigma about the victims protection, etc. So it's a lot of these different kind of frameworks who need to come together on this.
Yeah, thank you, Hannah. Marina Tondo, maybe you would like to unmute and ask your question directly, because I see that you've got some interesting information as well.
Sure. I was thinking, based on past experience, basically in some contexts, because I think we mainly right now talked about healthcare workers as primary point of entry for survivor, but also in other contexts where there are either for like one-stop shops or where caseworkers could also be the first entry point for survivors, or even volunteers or frontline workers. So where, and especially in contexts where the obligation for reporting a crime is broader, so it's not specific only on, for example, sexual violence or rape, but it's broader to any crime. So where then this first point of contact, which might be caseworker or volunteers, might be faced with that obligation. And I was wondering, often the actual questions for them, the supervisors and coordinators, were what do we actually do in practice? I noticed that also in training modules, this was not a big specific point of skills building or knowledge building, like what to actually do in practice for both specialists, caseworkers, for example, but also having the topic of mandatory reporting and what to do in practice with volunteers, for example, that might be frontliners that receive a first disclosure. So I was wondering if there should be more of a focus on also in training modules and in training curriculums on this aspect, especially since it's so context specific and different country by country.
Anyone have any thoughts on the trainings? I have seen some. I know at UNFPA Myanmar, way back when, we were trying to embed it in medical school curricula, but does anyone else have any thoughts?
I can offer a thought. Marina, you bring up a really important point, and I wanted to let you know about an initiative that's currently being undertaken under the auspices of the Global Health Cluster. There's an interagency group of clinical management of rape providing organizations, including WHO, UNHCR, and UNFPA, that have come together in order to try and harmonize a training package, a curriculum along with comprehensive facilitator resources and job aids for health workers that are going to be trained on clinical management of rape and IPV. And in it, there's a comprehensive module dedicated to national legal frameworks where we offer templates and we offer resources, not just for the trainer, but also for participants to really try to think about what are the critical questions that we need to ask in order to understand mandatory reporting procedures, and what are some of the enabling factors in the legal framework, and what does it mean in terms of some of the critical considerations that need to be made for health workers when they're confronted with a survivor. And just to return to an older point, I wanted to really emphasize that while we've been talking a lot about the imperatives that health workers have when they're with a survivor, we also need to think more critically about how are we enabling health facilities to put systems in place that would protect survivors. And that's why one of the major recommendations that we put forward is the confidentiality policy, where health workers are saying upfront to patients that these are the limitations of my role if you share with me that you have experienced abuse, et cetera, et cetera. So, really looking at what is the role of a health manager in supporting the work of a health worker, so that we're not putting inadvertently survivors in a position where they may disclose without realizing that that disclosure would be elevated. So I'll stop there. Also, the training package is due to be out by the end of the year. So, yeah.
And I know that WHO, as our key partner, will share it with everyone on the community of practice so that everyone can have access to that. We're reaching the end of our time. I'm going to ask Shiva to launch the poll for everyone to give us a little evaluation on this. And just draw attention to some of Yerim and York's comments in the chat about in Venezuela, how they can also depend on the empathy of the health personnel to go around this. And this has been something else that we did when I worked way back when in MSF. I won't speak for them now. I'm not sure what they're doing, but we also made sure that if there was only one person in the area who was allowed to do the forensic documentation that we provided, accompaniment, and transportation costs to make sure that that wasn't a barrier for women who wanted to receive access to justice. So finding ways around it is really kind of what we do in the GBV world, right? Trying to find out how we can work within the limitations of the law, advocate for more support from the law, change things, help our survivors, find creative ways around it. And so this fabulous panel has certainly inspired me to think more about this topic. And I want to thank you all for coming today, Hannah, for coming on your holiday as well. And thank you so much. We'll continue the discussion on the community of practice. I'll put the all the different materials that were mentioned in the presentations in the Dropbox, as well as sharing with you the PowerPoint presentations. And if you have any other questions or you need to get in touch with any of the panelists, please contact us at gbvcop@gmail.com and we'll make sure that you get them. So thanks again, everyone, and hope to see you again soon. Thank you.